Yeah, so when Rick and I were speaking about a year ago, because that was when the last week was, or the last meeting was, Airway was the thing. He's like, we got to hit it hard. We got to get into it. And I was like, okay. He was like, we got to talk about it, orthodontics and Airway and how that works with it. I was like, yeah, I can get something together for you. So this is the product of it. Now, before I get into it, disclaimer, if I don't talk about your specialty or what you do, that is not I'm not undermining your contribution. I'm so glad to be going right after summer because you did such a great job about speech and how they really get involved with this. So this is not to diminish this to anybody that I don't highlight specifically. So jumping into it, the title of the speech is Airway Orthodontics, but we'll get into why that might be kind of even a controversial or even misnomer for the nature of this presentation. So did some training. I see some Children's National people in here, some MUSC for sure. I got a dental school classmate, Andrew. Good to see you, bud. And so good to be close by. But acknowledgements here. Special thanks to Rick, Whitney, and Angie. I really appreciate the opportunity to be here. And when I was thinking a couple of days ago about coming up and speaking in front of the group, I started getting some anxiety, and I was like, why am I feeling anxious about this particular speech? And I was like, well, I need to talk about some things that really matter to me as well. And so one of whom, or three of whom, are the men whose shoulders upon which I stand. One is my father, for being the perfect example of what compassionate care and quiet leadership generally looks like. Another, Goody Thomas. I'm not unique in this. If Goody Thomas had an impact on your life, raise your hand. Right? So a lot of orthodontists in the room, pediatric dentists as well. And then he demonstrated how connection, consistency, and generosity can open doors. And the personal support he gave my brother and me, which was far beyond anything we ever deserved. And then lastly, Jack Burrow, for taking a very big gamble on his son's overly enthusiastic dental school friend and reminding us that mentorship can be both profound and accompanied by famously expressive vocabulary. His favorite word is the F word. And if you're around him a lot, you get to hear it a lot. And so I had about a year to prepare for this. So I hope it's not disappointing, the product of it. But the way I approached it was I wanted to, anytime there was a new article or a classic article, I threw it in a folder on my desktop. Anytime somebody was fighting something out in a Facebook group, I threw it in an article, or I threw it in the folder. Being in the pediatric groups as well as the orthodontic groups, it felt like I had some exposure to what people was trending. So take the article, throw it in a folder. I went through intentionally as I was reading these and wanted to pull out some of the most attention grabbing, we're going to give a speech about this, quotations. So one was a classic article, and Kate Vig did such a great job with the studies that she did to show some correlation between nasal obstruction and facial growth. But one thing that she said was strong convictions are often founded on weak evidence. And I look at her as one of the pioneers to really bring this to light and show that visually. Renshoes is always good for some good stuff. It said, airway friendly orthodontics, are you serious? In an editorial paper. Another one, a narrow maxilla does not automatically mean a narrow airway. Another one was everybody gets an expander, a satirical call out for overprescription in the name of airway. And then another definitive thing you'll see as a theme of the presentation is that orthodontists should not assume responsibility for the definitive diagnosis of OSA. I mean, that is something that we need to think about. That is from an AO white paper on obstructive sleep apnea. So now, why are orthodontists? Why is this something that we need to be brought into it? Well, orthodontists, we see children at growth sensitive ages. In fact, we plan to target those. A lot of the hardest stuff that we had to learn in orthodontic residency and continue to learn now is growth and development. How do we have the maximum impact on these children? We look at them growth sensitive ages. We follow them longitudinally. And especially is well placed to screen for craniofacial risk phenotypes, maxillary constriction, probably the number one thing you think of orthodontics and airway, mandibular protrusion, increased lower facial height, and to coordinate interdisciplinary evaluation when risk is suspected. So our goal here is to say, okay, orthodontics and the airway. We're working in that range. So we know we have anatomic changes, right? No doubt about it. You expand a kid, you get a diastema, that is a skeletal change, right? So, but from anatomic promise to physiologic proof, can we back that up? So whenever orthodontics comes into the conversation for airways specifically, there's usually about 5 treatment domains that come to mind. Rapid maxillary expansion or orthopedic expansion, premolar extractions, that gets a lot of conversation as well. Functional appliances and face mask therapy. Additionally, we're seeing more even in the orthodontic research about myofunctional therapy as an adjunct. I'll have speech therapy in that as well. And then orthodontic surgery. What's really neat is a lot of orthodontists, there's braces on the teeth, so generally we take credit for the work the oral surgeon does, which is pretty nice in our literature. So the presentation relies heavily on systematic reviews, meta-analyses, clinical trials, and professional policy statements from both the AAPD and the people that put those together. I said it last year, I'll say it again, are my heroes because they synthesize all this information and say statements that hopefully have a meaningful impact and trickle down to delivering detailed care in the clinic. So usually we save references for the end, but just from a foundational standpoint so you know where we started. These are some of the articles. This is half of the list. This is half the list of the articles. So this list was about 3 times as long. Some of them you kind of throw away. And I was the person that determined what stayed. So there's selection bias in this, like just inherently. But I try to do it with some discernment so that we could get it together. Reading all those was fun. So why is orthodontics, why are we together here today in the room? Well, we all have identified that sleep disordered breathing in airway in children is an issue. It affects a substantial proportion of children and adults, with the pediatric symptom prevalence commonly cited around 10%, even higher when you put a comprehensive sleep study into it. Our role is, as children practitioners, is to identify problems and look for the under-recognized, right? The kids that are so bad it's easy, right? What about the kids that are borderline that needs a discerning eye and a provider to give compassionate advocacy for them? So that's where we really want to be. So with many children, clinically meaningful sleep disorder breathing remains undiagnosed, and that's well documented, is pretty prevalent through the literature that we reviewed. Now this is for comprehensive, just to have some key terms. I won't go into each of these specifically, but when the lecture is distributed, hopefully you can use this if there's some terms that you wanted to jump into. I don't use every single one of these terms daily, so I won't attempt to try to do so here, but some of them are relevant to what we'll get into. So it's important for us, today, my goal, and I think some of the controversy with orthodontics is that there's a question of scope. What does orthodontics consist of? Are we diagnosticians for airway? Are we diagnosing malocclusions and jaw discrepancies, right? And so my goal here is not to redefine orthodontic scope, right? So what we want to do is look at these associations and say, okay, what are they saying? Does that feel good? And so orthodontists should not assume the responsibility for definitive diagnosis in OSA. That's part of a lot of the providers in this room. We have resources and people that are very capable to do that and do it very well. The definitive diagnosis is appropriately made by a physician. So we think sleep physician and ENT is involvement there as well. Similarly, the AAPD stresses the orthodontist role in screening and referral, not medical diagnosis. So orthodontic interest super surged. It's one of these things, whether it's extractions or expansion or airway. You talk to the guys that have been doing it for a while, and they're like, oh, we're doing this one again. Well, we do have new technology, right? And orthodontic interest certainly has surged since imaging studies repeatedly documented that certain interventions enlarge upper airway segments. But the question is, how reliably do anatomic enlargements translate into better sleep physiology? So our goal here is to examine that and question that further. Now, I'm excited about oral maxillofacial radiology because you'll be able to answer this much better than I have, but I just simply want to touch base that there are imaging limitations, right? So that we found that there's poor correlation between CBCT volumes with physiologic endpoints of treatment. Additionally, CBCT is excellent at visualizing the morphology, but not pathophysiology. So we want to make sure that anything that we pair with from a static image on a CBCT is confirmed with appropriate medical conclusions so that we're not misleading parents when we're getting these conversations. I'll tell a parent, I can enlarge the maxilla all day. I can advance teeth, no doubt about it. I can predictably do it, I can prove it to you. Now, the response of the child, we need to help and collaborate to be able to do that. So, treatment modalities, we're going to jump into it. We'll start with expansion, we'll get into extractions, we'll look at airway effects, and then myofunctional therapy, as well as orthodontic surgery. These were the ones that Summer always pays attention during lectures. I remember this last year. I was like, right after you go, I'm so sorry, speech is not up here. It just did not come up with the literature that we had, but it should have been included. Jumping right into, and I'll give you kind of my 2 cents at the end of it after some conclusions. So I don't want to get bogged down in some of this will be, when it's distributed, you can go through it a little more deeply if you'd like, but rapid maxillary expansion continues to be the most studied orthodontic intervention with respect to airway. And it associates with consistent anatomic benefits, no doubt about it. Expansion works at the right age. And we've seen some cases that show airway volumes increase up to 30%. Some early work showed that 36% show immediate reduction in nasal airway resistance. And then comparative data, pediatric data, does show increased upper airway volume. Where it did not show changes was retroglossal area. So the major critique is that many of these studies do stop at anatomy, right? And it's nice when these studies are published. A lot of the journals that want to put them out there, they want impactful, hey, look at this, we did this, right? And so some of that might be misrepresented by other studies that didn't show something as meaningful. So, but the prominent meta-analysis on pediatric OSA concluded that RME can be effective in selected children, but emphasizes uncertainty around long-term stability and patient selection. Now, if I have a child that I feel is borderline, that has an air maxilla, and I feel like there's a chance that it could help them, and that's an appropriate part of their treatment, am I going to lean towards doing that? Absolutely. Right? So, but it's just, that is a gap within the data right now. Now, another modality, which is mini screw assisted rapid palate expansion, a little appropriate, a little bit more mature. They were seeing some much more promising effects there. Of course, here, what you're doing is you're trying to redirect those forces to the actual skeleton, the actual maxilla. So you were able to see more. And in this particular study, and this is, it was a randomized control study or trial, it was really nicely done, but did show that, that those skeletal-borne expanders did have a really large anatomic benefit, and there was some physiologic benefit seen as well in some of these later teens. Premolar extractions. Any study that we went through showed that it had a neutral effect on the airway. That's, I can't, I can't say it differently, right? Because, I mean, everybody has had a conversation, oh, extractions affect the airway. I'm not sure if that's in the back of Rick's mind when he's taking premolars out on an orthodontic case that's center. Thank you. And so I'm trying to back it up now. And it's an appropriate plan, right? I mean, just like the pediatric dentist, when you see that 4-year-old that's kind of a little fussy in the waiting room, you're hoping that kid doesn't have cavities, right? You don't want to deal with that. I see a patient coming back with some crowding, I'm hoping I don't have to take teeth out. I really am, right? But there's some periodontium, there's some biological limitations that we need to be respectful of. But under nothing that we could see with the articles that we reviewed, nothing of a change could not be explained by regression analysis or just natural growth. So I'm sure the conversation still goes, but neutral effect, we're good. Functional appliances, face mask therapy. As you would think, anytime you're trying to bring something forward, there should be a change, a positive one, right? Especially if the diagnosis is protrusion. When you're putting a functional appliance in on a child, generally they have a protrusive profile, particularly mandible. That's why we're going to do that. And ideally, the upper jaw is sitting a little bit more forward, so you can kind of help to balance between the two. Face mask therapy, trying to advance that as well. What we found was that there was moderate evidence for small anatomic gains, but limited evidence that such gains improve sleep outcomes. Now, you may notice something transient, particularly while the kid's wearing the appliance initially, right? The kid starts with 12 millimeters of overjet, and you're being real heroic to try to correct it with a functional appliance. Spence is like, yeah, I had one of those. I had a bunch of those. And you put it right in there, kid kind of perks up, breathing a little bit differently, but the long-term effects are still something. Now, that might make somebody like Rick cringe because he's like, well, I want to get in there and bring that mandible forward like we mean it. Y'all quit playing with these functional plans. Okay, we'll get there. And then, and orofacial myofunctional therapy, this was really impressive. So now the evidence was a little bit tough. So if you had to grade the evidence level, it's kind of lower evidence, but it did show that with training and, training the drivers, right? That type of approach showed a really positive impact. Now, the challenging part about the therapy component is you can't isolate it, right? Because it all has to be done together. So that's the only reason I could see to have that there's a low evidence for it, simply because there was so much confounding with it. But promising adjunct, it's not a standalone, and we could really benefit from some higher quality information there. Now, orthodontic surgery, of course, anytime you talk about it with orthodontists, this is going to be coming up. By far the most meaningful, dramatic change you can have. I don't think that shocks anybody in the room, right? When Jack, who mentors me, continues to, he tells in the new patient exam, he's like, yep, because y'all needs to come forward 7 millimeters. He goes, I'm an orthodontist, I can't do that. We know surgeons, they do it very well, and they do it in about 30 minutes. Like they'll take care of you. So what we do see, particularly with maxillomandibular advancement, right? And this is a lot of the Stanford studies. I've seen some of them referenced already today. Average increase of about 50% of that airway volume. AHI reduction, so it takes them to a score that's severely OSA to a mild, and that's an 85% reduction that was reported. And then the surgical success rate for adult OSA patients was 86%, right? So this information shows that pretty high evidence, and this is going to be absolutely one of the things you should consider if there's a larger event. Finally, something that we talk about a good bit, you've always heard, mandibular setback surgery does have a tendency to encroach the airway, so should we approach that differently rather than a single jaw in those cases. So, but we did see consistent anatomic reduction, pretty intuitive that you would see that after mandibular setback. So we need to be airway aware when we're planning for that, and then informed consent, of course. So weaknesses, I've touched on a couple of them as we've gone through. Study design flaws, we have short follow-up periods. There's some outcome mismatches, so CBCT, does that equate to it? And they haven't been able to directly connect it. High heterogeneity, meaning that there's a lot happening for these kids at one time. So how do we isolate these effects? Uncontrolled confounding, very similar to the last one. Then some publication bias as well, not to mention the selection bias that I infused into it as well. So if you're looking to take a picture of one, this is probably the one worthwhile to do. Trying to bring it all together, broken down by treatment modality, It's a typical anatomic effect, right? What are we going to get? And then what is the physiologic outcome of that input? We graded it on I graded it on the strength of evidence, and then how do we practically apply that? What is the position of the information that was available? Where do we go with it? So for rapid maxillary expansion, the anatomic effect, we increase the nasal and nasopharyngeal volume. We do see some reduced nasal resistance in some studies. The long-term effect on indices is unclear. The strength of evidence is moderate, and it's a useful adjunct, particularly in growth, but we want to avoid curative claims, right? This is going to fix your kid. This is going to help your child. We believe this is going to help your child. We're going to have to monitor that closely. MARPE, greater skeletal widening, as we would think. Improved nasal airflow, moderate to high. But there's one randomized control trial, right? And then consider this for skeletally mature patients needing expansion, intuitive, right? Premolar extractions, good to go, right? Do not avoid extractions solely for airway concerns. I feel like after my comments, I take teeth on everybody, I really don't. But it's safe when necessary from an airway perspective. Functional appliances do increase volumes, uncertain about clinical effect, moderate strength for that conclusion. And so you get modest anatomic gains. You want to verify function if airway is a goal. Face mask, kind of similar, unclear about physiologic outcome, low to moderate strength of evidence. Structural adjunct, I wouldn't market this as airway therapy. Myofunctional therapy, improved tone, favorable craniofacial trends, reduction in AHI, low evidence with what I looked at, but it's adjunct, and then standardized protocols and tests and make sure that we're staying on top of it. Maxillomandibular advancement, high success rate, high strength of evidence, evidence-based airway surgery, right? And then mandibular setback, moderate strength of evidence, transient sleep quality decline, long-term risk is uncertain, but we want to make sure that those patients are counseled appropriately. So this is not the final slide, but the conclusion of what we've processed to this point, and then I'll give some insight and I'll get off the stage. It is remarkably easy to fall in the correlation causation trap when interpreting relationships between orthodontic treatment and airway changes. So the central conclusion is straightforward. Orthodontic and dentofacial orthopedic interventions can and do change airway anatomy. Whether to what extent they routinely and durably improve airway function during sleep remains unproven for most modalities. So where do we take this information? So this is my best approach to try to be pragmatic. So orthodontic, orthopedic, and orthodontic interventions can meaningfully influence airway structure, especially in our growing patients. Expanding the maxilla or advancing the mandible may create a more favorable anatomic environment for nasal breathing and airway stability. Premolar extractions, when chosen thoughtfully and biomechanically planned, remain an appropriate and effective treatment option and do not inherently compromise airway health. Airway function is not determined by structure alone. Neuromuscular tone, sleep physiology, inflammation, and breathing habits also play major roles. Orthodontics addresses structural components but should not independently diagnose and treat sleep disorder breathing. Collaborative care is essential. Myofunctional therapy assists with tongue posture and oral muscular coordination. ENT specialists address nasal obstruction and airway tissue concerns. Pediatricians and sleep physicians evaluate sleep physiology, neurocognitive impact, and medical contributors. And then oral surgeons address skeletal deformities and deficiencies, which can have a profound impact on airway volume. The most successful patient outcomes occur when structural changes are paired with functional and medical support. And this approach keeps treatment evidence-based, patient-centered, and interdisciplinary rather than driven by trends or ideology. So as far as practically integrating this for an interdisciplinary team, we need to know when to screen and refer. We need to choose our growth windows wisely. I know I've heard Rick say before, just because you've got a small kid, it's not a continuum of treatment until they age out of being able to come see you. We need to select our expansion strategies by maturity. We don't need to fear appropriate treatment if distractions are involved. We need to reserve surgery for surgical problems. And we need to be transparent about uncertainty. CBCT is a great tool, but we need to make sure that we verify those physiologic improvements and also know when we didn't get it so we know what to do next. Final slide. Our obligation is not to prove that orthodontics improves the airway, but to prove that what we do improves the patient. So our goal today in this room isn't to redefine what the scope of orthodontics is. It's to redefine or refine how we're going to collaborate. Thank y'all. I appreciate it.